Hello and welcome to our webinar series, Next Steps in COVID-19 Response and Long-Term Care. I'm Andrea Piche, Senior Program Lead here at Healthcare Excellence Canada. My pronouns are she and her, and I'm pleased to be your host today. I would like to start by acknowledging that we are meeting on land that is inhabited by Indigenous people since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. We're pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We invite you to share your questions and comments at any point using our chat box in either English or in French. And we encourage all of you to respond to each other's comments and answer questions in the chat as well. We will aim to connect as many of your questions as we can with our speakers during the Q&A, which will come at the end of the webinar. If you need support at any time during this webinar, you can reach out to tech support using the chat feature. This session is being recorded and will be available on our website in the next couple of days to review or to share it with colleagues who might have missed it. Today, we are pleased to have two speakers from Healthcare Excellence Canada to talk about some very recent work on engagement-capable environments. I'm very pleased to introduce my colleagues, Carol Fancott and Adrienne Zerum. Carol has led the co-development and co-delivery of programs and activities that focus on the needs and priorities of patients, caregivers, and communities. A physical therapist by training, Carol also obtained a PhD at the Institute of Health Policy Management and Evaluation at the University of Toronto, where her dissertation focused on patient engagement and storytelling for organizational learning and improvement. Building and strengthening relationships and engagement and partnership are central to her work. Adrienne is an embedded patient partner with Healthcare Excellence Canada and a passionate advocate for patient engagement and partnership in healthcare improvement. After her youngest daughter was diagnosed with autism spectrum disorder, Adrienne embarked on a journey to partner with local and national organizations to help advance patient-centered healthcare through effective and meaningful patient and family engagement. She's a past co-chair of Holland Bloorview Kids Rehabilitation Hospital's Family Advisory Committee and a graduate of Canada's first Family as Faculty program, a parent advisor and hub team member of ECHO Autism Ontario, and one of Canada's first patient surveyors with Accreditation Canada. So happy to have both of you joining us. Carol and Adrienne, I'll turn it over to you.
Thanks so much, Andrea. Carol and I are thrilled to have been invited to join you all today. And sorry, I just realized my camera wasn't on. There we go. Really invited and really thrilled to be invited to join you here today. My name is Adrienne Zerum. My pronouns are she and her, and I would like to acknowledge that I'm joining you today from my home office in Midtown Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. So next slide, please. So in the time that we have together, I'd like to first do a little level setting to ensure that we're on the same page when we're talking about engagement. So first we'll define some common terms, and then we'll have a look at a few classic frameworks to ground our work. Second, Carol's going to give a bit of an overview as to what has happened to engagement during the pandemic. And then finally, we'll both look to the future and introduce you to a recently developed tool that is helping organizations create and sustain engagement-capable environments. And before I get into the meat of things, I just like to acknowledge that the bulk of engagement literature refers to those being cared for as patients. But that being said, most in this field would believe that it's perfectly reasonable to assert that these concepts and these practices that we'll discuss today are relevant in a long-term care setting, and in turn, relevant to residents as well. So Carol and I will do our best to use the language of residents as best we can, but please do forgive us if we reflexively say patients sometimes today. So next slide, please. And as I mentioned, before we dive in, I'd like us to do a little level setting to ensure that we're clear on the language that we're using. So next slide. So on this slide, you'll see several interrelated concepts. Engagement-related terms that articulate the current philosophy related to engagement, that of person-centered care, the approach to engagement, that of patient, or in this case, resident and family engagement, and finally, the outcome, that of patient or resident experience. So first, let's look at the concept of person-centered care as a philosophy of care. And if we look to the World Health Organization and their 2013 policy framework on people-centered healthcare, they note that the overall vision for people-centered healthcare is one in which individuals, families, and communities are served by and able to participate in trusted health systems that respond to their needs in humane and holistic ways. The health system is designed around stakeholder needs and enables individuals, families, and communities to collaborate with health practitioners and healthcare organizations in driving improvements in the quality and responsiveness of healthcare. And people-centered healthcare is rooted in universally held values and principles, which are enshrined in international law, such as human rights and dignity, non-discrimination, participation and empowerment, access and equity, and in partnership of equals. And people-centered care aims to achieve better outcomes for individuals, families, communities, health practitioners, healthcare organizations, and health systems by promoting a culture of care and communication, responsible, responsive, and accountable services and institutions, and supportive healthcare environments. So then if we look at patient or resident and family engagement, this is an approach to engagement and can be used at various levels of the health system, from the direct care level right up to the organizational and system level. And patient or resident experience is an outcome that is influenced by the approach to care. So patient or resident experience is an assessment of their care starting from the first time a patient or resident connects with the health system. And that assessment is influenced by the processes and the physical settings of their care and by the relationships that are developed with their care providers. So next slide, please. So let's take a minute then to look at the evolution of engaging patients or residents over time at that direct care level. So this figure actually comes from Dr. Marie-Pascale Pommier's work through the Center of Excellence on Patient and Public Partnership, or CEPPP, at the University of Montreal. And she and her colleagues explore how patient partnership has evolved, how it's moved from a philosophy of perhaps paternalism to one of patient or resident-centered care to where the field is moving, which is partnership in care. And if we think about how our health and care system was structured not so many decades ago, the system was indeed based on a philosophy of paternalism. It was a system where we did two patients, a time where we might say the doctor knows best, and where it was typically a provider's job to work with other providers to decide what was in the best interest of a patient or resident. And if we're honest, we do still see some remnants of this in some of our practices, perhaps in hospitals where providers may round outside of a patient's earshot or far away from them. That being said, we're making inroads, and practices like bedside rounding are becoming more and more prevalent. So currently we're moving away from this paternalistic philosophy and way of working, and patients and residents are now becoming more and more active in their own care and in their care planning. And we're moving towards a more patient-centered or resident-centered philosophy of care. And here patients or residents are placed at the center of the health system's efforts. They have a team around them, and they're now involved in their own care. And while I would argue that this indeed is a move in the right direction, absolutely, you'll notice that in a sense, we're still doing for patients because patients and residents are not yet part of their care team. And if you look carefully at that patient-centered care illustration, that one in the middle, you'll see that the patient or resident is encircled by their healthcare team. And while the team members are connected, there are no arrows between the providers, meaning that they're not necessarily communicating with one another. And there are lots of bidirectional arrows pointing to and from the patient or resident. And while I'd argue that this is indeed a far superior position to be in versus being outside of that circle, Having lived the last 10 years in that circle, I can share with you that it can be a really stressful place to be. Patients, residents, and families are tasked with distilling loads of information from many, many providers, and it's not an easy job. In fact, it often is a job in itself. It's the reason, I left my job in clinical care to take on the job of managing my daughter's care before I was privileged to have this role at HEC. So despite the fact that the patient-centered or resident-centered philosophy of care is a huge step in the right direction, perhaps where we'd like to go is where Dr. Pommier and her colleagues illustrate in that far right description to a philosophy of partnered care, where patients or residents are now part of the care team. And instead of doing for them, we're working with them. We're inviting them to be part of informed decision-making and helping them to develop the competencies that will allow them to better manage their own care. So that's the direction that many of us are hoping that our Canadian system is moving in. And we'll see when we look at the evidence that there's many, many good reasons for us to move in this direction. So next slide, please. So next, we'll explore two well-known patient engagement frameworks, one from Christine Carman and her colleagues, and another from the International Association for Public Participation, or IEP2. And you'll see here the Carman framework, and this one helps us identify patient or resident engagement across a continuum and illustrates ways that we can engage patients or residents at 3 different levels. So you'll see in red, the organizational design and governance level, where many of us do our work. You'll see in green, the direct care level, and in blue, the level of policymaking. And you'll note that the continuum of engagement is broken down into 3 ways of engaging. The first being that of consultation, the second being that of involvement, and the third being that of partnership and shared leadership. So at the organizational design and governance level, when we're consulting with residents, we may be surveying residents about their care experiences. When we're involving residents, we might be involving them as advisors or advisory council members. And finally, if we're moving towards partnership and shared leadership, we might be having residents co-lead safety and quality improvement committees together with leaders and staff. So next slide, please. And here you'll see an illustration of the International Association for Public Participation spectrum of engagement. And although this framework is not specific to healthcare, it is indeed used by many healthcare organizations. And it's often cited in the engagement literature. So here the spectrum of engagement is broken down into 5 different ways of working: that of inform, to consult, to involve, to collaborate, and then to empower. And the framework notes not only the goals of participation or engagement, but the promises made to people that are being engaged. And so from here, I think what I'd like to offer is there's no right way to engage with patients or residents. There's value in engaging at each and every level on the spectrum. And ideally, during a project that engages people in a fulsome way, patients or residents would be engaged across all levels of the spectrum at different points in time during a project. So next slide, please. So I hope that was helpful to give you a little primer on engagement. And I'd like to now hand it over to Carol, who's going to talk to us about what happened to engagement during the pandemic. So Carol, over to you.
Thanks so much, Adrienne, and thanks for the invitation to join all of you today. And this notion of being able to set the foundation for engagement, we like to do that because often there's confusion among many of the terms that we use. So patient, resident, family engagement that happens, but as well as Adrienne very aptly spoke to around person-centered care, person-centered practices and philosophies of care, and also around experiences and how are they all interconnected. So, I want to just give a quick overview then, of what happened to engagement during this time of the pandemic, to help us think forward into how are we then building back better in this area. And so The field of engagement has had remarkable growth over the past decade, and really where there are increasing expectations of patients, of residents, of families, of caregivers to not only be involved at the direct level of care, but as Adrian had shown, at multiple levels of the system, to be involved in improvements in processes and systems in care, in policymaking, in research. And the core of all of this engagement is to better understand the lived experiences of those receiving care. And it is these experiences that can help drive where the priorities are, where the opportunities for improvement are. And we know from the emerging literature on engagement that it makes a difference. That we have seen in areas, particularly in our area of where we focus for Healthcare Excellence Canada, improvements in quality and safety, that we are seeing improvements in experiences and outcomes, and not only for patients, residents, and caregivers, but also for healthcare providers. So improved staff satisfaction and retention, and being able to promote joy in work when those connections are made, those human connections are made. And we have made great strides over the past decade to ensure that these experiences of those receiving care are really helping to drive changes in the system. And so, to be quite honest, it was a bit of a shock to the system to see, particularly in those early days of the pandemic, how many of these gains seemed to disappear. And we know there were many unknowns, and there was many changes that needed to be made at a rapid pace, both in policies and processes of care. But it was somewhat demoralizing to realize sort of that tension between person-centered and partnered practices and what was done particularly in those early days of the pandemic and in trying to keep people safe. But how many of these changes were done without input or involvement of those most impacted by care. So if we move to the next slide, what we have learned through a study by Dr. Julia Abelson and colleagues from McMaster, where they surveyed hundreds of patient partners across Canada, that particularly in the early days of the pandemic, almost a quarter of patient partners reported that engagement work had stopped altogether. Approximately 62% reported that there were temporary or partial stoppages in engagement work. And then remarkably, around 11% said that engagement actually increased for them in organizations where they were connected with. And so I would like to point out that these organizations can range across health and care settings. So in healthcare institutions like hospitals and rehab centers, but also in long-term care, other congregate care settings, and in the community where patient partners, so patients, residents, caregiver partners are engaged across the health system. And so if we look at the next slide, so what have we lost when we're not engaging in care? What we have seen, particularly at the direct level of care, are many devastating impacts when patients, residents, and their caregivers are not engaged. And in particular, where we have seen essential care partners, so those families, friends, caregivers that have been identified and designated by residents who are not allowed to be physically present to partner in care. And we know there were many reasons for this, particularly back in those early days of COVID: staff shortages, lack of PPE, fear and uncertainty about the virus. But as the literature continues to emerge through COVID, we have seen the many harms that have resulted to residents, to their families and caregivers, and to staff and providers related to both safety and outcomes of care and experiences. At an organizational level, we know rapid changes were being made, both policies and practices. And for the most part, many of these changes were made without full involvement of those that were going to be most impacted. And again, what was shocking was sort of that realization that the philosophy of care, particularly around person-centered care and partnered practices, seemed to disappear overnight. And when the crisis hit, the default seemed to go back to more paternalistic patterns in decision-making and top-down approaches. And again, at the system level, many pivots and shifts were being made to respond to the uncertainty of the pandemic, but without fully accounting for the other potential risks that could emerge with these changes being made. And again, this is not to blame anybody for the changes. We were dealing with so much uncertainty at the time, but it's now, what do we do with what we have learned? And so, what have we gained from through this pandemic? And there are always silver linings that come out. So I'll ask you to go to the next slide, please. With any crisis, there are gains that are going to come out. So the rapid shift that was made to virtual care, similarly, virtual engagement methods started to happen as it was seen as a safe method for people to gather. There continues, obviously, to be concerns about the digital divide that exists. But for the most part, many found that they were actually able to widen their circles of engagement to include many more people with diverse perspectives that can now be involved because they could attend meetings virtually. Engaging, though, through virtual means does create a different dynamic, but overall, people found that they were able to engage effectively. There were new structures that developed that didn't exist previously. Examples of rapid response tables, for example, that popped up. I'm thinking of one particularly in Quebec that really helped to support the provincial government on a number of key issues. And that for many engagement efforts help to build and help to regain trust and to strengthen relationships. So next slide, please. What enabled these gains? We've been working with a researcher from U of T to really dig into a number of cases across the country. When I spoke earlier about that earlier study, about 11% that actually found they were increasing their engagement efforts. How did this happen? And so leadership, we cannot understate the value of strong leaders that create the expectation for engagement even in those tough times, understanding that it needs to be done differently, but truly put the value on the lived experience and understanding why that lived experience needs to come into decisions that are being made. Maturation of context really refers to those organizations that truly had a person and centered and partnered philosophy well ingrained within their organizations already. And with this, they were more mature in their efforts for engagement, but also had trusting relationships already formed and existing structures that were there within their organizations that supported these engagement efforts that they could turn to in these times of crisis. And then interestingly, this notion of the willing partners, patient partners, family partners, resident partners that willingly put their hands up saying, we want to work together with you. We know that rapid change needs to happen, and how can we help? So if we think about what we have learned, what enabled these gains, if we turn to the next slide now, how is it that we're going to take what we learned to build back better? How do we create, build, and sustain these environments that lean towards engagement, that don't shy away from it in times of crisis, but lean into it, that understand its value and make it a cornerstone for how they're going to work, whether in times of crisis or not? And so this is a term, engagement capable environments, that really was coined through work that we have done. And if we go to the next slide, um, when we talk about what this means to engage at all times, it really is about culture change. It's embedding that culture of person and family centered care and partnership, and recognizing and valuing the wisdom of lived experience of those receiving care and the care partners that will drive improvement efforts. And when we're doing engagement well, not only is it about those receiving care, it's also about those providing care, because we're working in partnership and coming to solutions that are going to work for all. And so engagement capable environments understand that health and care are human endeavors. They're built on relationships, and that engagement needs to happen across all levels of the system, at the direct level of care, but also at those meso and macro levels, at organization and system levels. So the next slide. Engagement capable environments are really built on these three main pillars that interact. There are the health and care leaders, the staff that are working on the engagement activities together with the patient partners. And again, patient partners that include those with lived experience, the residents, the clients, and their caregivers. And all of these pillars are interdependent and they're necessary to create that desired culture for engagement. And again, relationships are at the core. So we're going to get into this organizational self-assessment tool that we developed here at HEC. If we move to the next slide, please. And this is a tool that was built not only on what we at HEC have learned by working with dozens of organizations across Canada and supporting their both engagement efforts and improvement efforts, but as well ongoing engagement with dozens and dozens of healthcare leaders, engagement leaders, and patient partners across Canada. So this is very much a practice-based tool. It is a self-reflective exercise that is really meant to include everyone that is involved in engagement, and it can be used in a broad range of settings. In hospitals, in long-term care and other congregate care settings, in research settings, and it can be used both at the organizational level, but as also at the project level. If there's a specific team engaged in a particular project together with resident and family partners. And it gives a sense of what currently is happening with engagement efforts across the team, across the organization, and it helps to identify those areas for improvement and to reflect upon more as you're moving into the future. If we move to the next slide then. So the tool itself is designed around those three pillars that I talked about: leaders, teams, and patient and resident partners. And so if we look at the tool itself, and I think it's going to be dropped into the chat box shortly, we'll start with the pillar of leadership. What does it mean for leaders to set the tone for engagement, to develop those structures that support engagement, and to role model the behaviors expected of others? And so if you look at the tool, there are a number of elements to consider. And so when we think about it, what is it? And if we go to the next slide, please, what is it that leaders actually do? When I think of cases that we've done in the past, as well as most recently looking at cases throughout COVID-19, leaders set the clear expectations for how engagement happens and how consistently it needs to happen. And I can think of leaders that would always ask this question when new things were brought to them, new initiatives, changes that were being brought forth, a simple question of, how is it that patients, residents, families, caregivers have been involved in this work? How do we know this is a need? How do we know this is a priority based on the perspectives, that lived experience perspective? And by that, they are not only demonstrating the value for lived experiences of those receiving care, they're also validating this as a form of knowledge that is being used then to drive improvements. Leaders also understand that meaningful engagement doesn't happen off the side of someone's desks, that you need to develop the resources, the structures that will actually support the engagement activities, and that there needs to be strategic alignment, that it's clearly stated that there is a strong underlying philosophy of person-centered and partnered care, and that there is strategic alignment to this philosophy of care to enable the engagement to happen and to move forward and to really create the accountability necessary to put action into this philosophy of care. So I'm going to pass it over to Adrian now to talk more about leadership and then to move into the other pillars of engagement capable environments. Back to you, Adrian.
Wonderful. Thanks, Carol. Yeah, I'd say that, one of the most important things that leaders can do to help support an engagement capable environment is to set that tone and to role model engagement efforts to others. And so this means that leaders role model those behaviors necessary for authentic engagement, including active listening and openness and transparency and humility. So when I had the great privilege of surveying a number of long-term care homes in my role as a patient surveyor with Accreditation Canada in Ottawa last year, I came across a home that was firmly committed to their engagement practices with residents and families. And this was evidenced by how actively they were listening to and communicating with residents and families. So leaders were on the phone day and night talking to residents and families about how the public health measures were affecting their homes. They were being honest about the struggles that they were having, even when it was messy. And they were listening to what mattered most to residents and families. And they got really creative. The staff actually banded together to raise money for the home so that every resident could have an iPad to communicate with their loved ones and their essential care partners when they couldn't be in the building. And they did their best to maintain open lines of communication, even when physical access was limited. So on to the next slide. The next pillar is this pillar of patient partners or resident partners. And this pillar identifies attributes of organizations that provide opportunities for partners to engage and to develop their capacity as partners. So on the next slide, we'll see that one of these attributes in practice looks like patient partners or resident partners being prepared to participate in an engagement opportunity by being provided with an orientation, with appropriate materials, and being provided the opportunity to ask questions and to seek clarity in advance on anything that they're not clear about so that they can really contribute to their full potential. So at the organization that I partner with, we participate in one-on-one orientations prior to doing any partnership with. We have a contact person we can connect with if we have questions, and we often are provided with orientation materials prior to initiative so that we can really understand what we're being asked of before we get on a Zoom call or sit in a board meeting and have the information presented and sometimes feel like we're a bit lost. So that on the next slide, we will talk about this final pillar, which is that of the pillar of staff and healthcare teams. And the tool articulates how teams and staff can be prepared to engage and how to operationalize those principles of patient and resident centered and partnered care. So next slide, we'll look at, what does this look like in practice? And I think it really looks like staff and healthcare teams being conscious of those power imbalances, one of these things, that can be inherent on teams when people have many different roles. And it often includes, just using first names. So first names so that we can try to lessen those power imbalances and to signal to everyone in the room that every voice there is necessary and important and valuable. And it looks like staff creating an open and a safe and welcoming environment. And this can start as simply as doing proper introduction. So patient partners can understand who it is they're working with and feel really a part of the team. It also means that we think about cultural safety and we ensure that we appreciate that when we invite partners to work with us, that we acknowledge that they may have different worldviews than we do. And we need to be sensitive to this and responsive to this. And during one of my visits to a long-term care facility last year, one resident partner told me about a neat time when he had been invited to participate in the groundbreaking of a new home that he had participated in kind of designing and putting together. And so prior to the day when they were going to have the groundbreaking, one of the home staff went to the site hours and hours early and realized that there was no smooth path for this gentleman to be able to get up to the podium to speak to the group. And he had been invited to speak about his partnership on the team that had helped kind of develop the plans for this new home. And so because there wasn't a path, apparently the staff went with shovels and rakes and literally raked out a path to make sure that he could get up and speak on behalf of the team, because he was a valued member of that team, and the staff thought it would be obviously very important for him to be able to have what he needed to contribute and for the team to be able to acknowledge that his participation was really valuable. So next slide, we'll identify a few places to start. So firstly, that patient and resident engagement is really about understanding the lived experience of others, understanding that their experience may be different from yours or ours, and using that as a launching point to reflect on how things could be better. It's understanding, particularly in our evidence-based world of healthcare, that evidence and knowledge comes in many forms, including that of lived experience. And it's important to bring humility to this work. Leaders and providers may be experts in some things, in many things, but residents and families hold the expertise in their individual lived experience. They live this life every day. And it's important to remember that relationships are really at the core of all engagement work, and that fundamentally, healthcare really is a human endeavor. And in this pandemic, it's been revealed to us that there are inequities that exist in society and in healthcare, and that we need to be attentive to these inequalities. So I'd encourage you to think about who you're engaging with and who you're not, and how you might be able to be more inclusive in your work. And finally, I'd make a suggestion to just start. It's never going to be perfect, but if you go in with an open mind and an open heart, it'll be a journey. You'll make mistakes. We all do. This will never be the same twice, but it's best to just get started. It's the easiest way to move forward. So in the next slide, I'll end with a lot of resources we have on our legacy organization's website, a patient engagement hub, where you'll find lots and lots of tools to engage for engagement for our patients, residents, and families to improve the quality and safety of healthcare. This hub's going to be migrating to our HEC website shortly, but we're consistently updating it to make sure it has timely and relevant resources. And on the next slide, you'll see that there's been lots written on engagement capable environments in Longwoods, a casebook back in 2016, a special edition of Healthcare Quarterly, and a casebook that will be released later this year, talking about engagement capable environments during the pandemic and what has been learned. So on the next slide, we'll see lots of resources, some of our favorites, many of that we spoke of today, many from the BC Patient Safety and Quality Council, Health Quality Ontario, and Alberta Health that are really wonderful references. If you like podcasts, Matters of Engagement is a critical look at this work of engagement. And near the bottom, you'll see a link to a learning series that HEC hosted on equity, diversity, and inclusion in engagement that was quite well received. So on the next slide, you'll note our contact information. Carol and I are always happy to talk about engagement, so please feel free to reach out. This is where you can find us, and we're very happy to take questions.
Well, thank you so much, Adrienne and Carol, for presenting your work and for stimulating, I think, some conversation that I'm seeing in the chat around the translation of these concepts, these principles specifically to the long-term care environment. And what I'm really appreciating is that there's some sharing and peer-to-peer learning happening in the chat, around how do we take what you've presented and use the language of long-term care and in order to make this really resonate. So for instance, changing the word facilities, over to home, right? Because I think this is one of the unique differences in long-term care is that they're not in a medical setting, they're in a different home. And so, taking these concepts and applying it not just to their care in the sense of clinical care, but to their well-being of their life in their homes. And so I think that this audience is a great resource for helping to make the translation of this important philosophy that it absolutely applies to long-term care, really, really relevant. So thank you to those who are sharing and sort of doing some bidirectional learning with us here at Healthcare Excellence Canada to really make sure that the messages and the philosophy that is so important, to help us translate that to the range of environments where it is relevant. There was a comment that was raised and then echoed in the chat around, including the voices of residents with communication difficulties. And so, those with language, cognitive speech, hearing impairments, and how do we ensure that we have the specialized support and that in our environments, we are creating a place for voices of all natures, types, and abilities to come forward authentically. So maybe I'll just offer that up to you, Carol and Adrienne, as for a space to comment and to share from your perspective.
So maybe I'll jump in since I was unmuted, and then I'll certainly, I'm sure Adrian will have more to say. I think this is a great it's a great question, and it really speaks to those issues of diversity, those issues of how we create inclusive spaces, and what does this look like, and in your context within homes. Um, I think the first thing that I would say is when we talk about, we use the language of patient partners, and as Adrian said from the outset, it really is meant to be an all-inclusive term. So both resident partners as well as family partners. Often has been the case is the inclusion of family members that really help to, I guess, share and provide experiences from their perspectives, but but also understanding that they cannot and do not speak on behalf of their loved one who may have very different experiences. And I think in the case that you've noted of, I think it's being creative in how we understand lived experience, and how we are inclusive. So I was thinking about some research that I had read, and this is a while ago, about understanding those with dementia and sort of meaning of quality of life, and how they were using a lot of through the research, being able to relay some of those findings through very creative mechanisms to help people understand what those experiences may be like for those that are unable to share or communicate due to, in this case, it was more cognitive difficulties, but also language and speech. So I think it speaks to how we need to broaden our engagement methods to be much more creative in terms of how we're being inclusive and how we are reaching out to those more diverse perspectives to get it. But it's also, as we know in many cases, that again, I'm not the proxy version of trying to understand certainly who a resident and their lives may have been before they entered the long-term care home, through stories and experiences that may be shared through families and other caregivers as well. So I don't think that was a specific answer to your question, other than to say, these are things that we're always thinking about in engagement and that we're grappling with, but are much, much more attentive to ensuring that we are casting our net wide to get those broader experiences that we generally don't hear.
Yeah, and I would just add, I think that creativity is really important. And so you absolutely, when there are supports related to speech and language and to communication in homes, tapping into those. But there are also supports related to the arts and to other ways in which people may be able to kind of identify their needs and their desires. And so utilizing those structures and those skills within those homes to be able to bring in a diversity of perspective, because it might not be reasonable for a certain person to sit in a room and express themselves verbally, and perhaps it would be more reasonable to sit with someone to create, to use art, to use some other kind of medium to express how it is that they feel about something, or how what changes they think should be and needs to be made in the home. So I think there are lots of different supports in long-term care homes that, if used creatively, can really help to increase engagement with residents and essential care partners.
Thank you both. And I guess one sort of more practical add-on, tag-on question is, within the ECE framework's assessment tool, would this notion of accessible communication, where would that show up? How would people who are using this tool to assess their own environment tease out this type of an issue in using that assessment tool?
That's a really good question, Carol. I would turn to you. I'm trying to think about where in those attributes you might find that.
Yeah, sorry, Andrea had a sticky mute button there. So we talk a lot about methods of engagement, and that within, I think, I can't remember if it's under the leadership pillar or the staff pillar, but this notion of creating many different opportunities for engagement and what that would look like, and the forms that it could take based on the needs of the partners that you're trying to engage with. So it's because there's not only, as Adrian showed, in the spectrum of engagement, there's many different ways to engage, but then within that, there's many methods that we could potentially use to ensure that we're getting. The other thing that it would point to is just the issues of diversity and inclusion that we are being, as I said, much more attentive to in our engagement efforts. And that's also in the pillars.
Great. Thank you both. Another theme that's coming up in our chat has to do with, in the inclusion of the Indigenous perspective. And specifically, there was a question around inclusive language that recognizes cultural safety, and a question of, is there a suggested term for persons living in long-term care that identify as Indigenous? So the rationale for the question was that they're looking for an alternative to resident, which is a term that has many negative connotations and linkages for Indigenous people. And again, throwing this out, it's specific to a specific community within long-term care, and recognizing that you have, this is a very broad tool made for all environments. But I invite our entire audience, this is a question for all. I'm just elevating it as well. So please use the chat feature as well if others on this webinar have got some experience in how to, address those terms in a culturally safe and appropriate way. And so I'll pause in case, Carol or Adrian, you have any thoughts or ideas, and if not, that's okay. Perhaps some more peer-to-peer learning here.
I mean, thank you for raising that. And I will say that there has been conversation within HEC talking about language. And, we're always, we recognize that it's hard to land the right language to be inclusive of what we are talking about. And, as Adrian had sort of set us up from the outset of our initial sort of entering the space through the lens of patients and understanding that's not necessarily the term for everyone. And then in this case of resident, and definitely engaging in conversations with others around what would more appropriate language be. We definitely talk about, from the patient engagement aspect of, those with lived and living experience of the health system. For long-term care, I am seeing one here saying person living in long-term care. I think it's, this is a field, the engagement field is one that is fast moving and has been in evolution, I would say, definitely over the past decade. And so, what we talked about a number of years ago definitely isn't how we should be talking about it today. And I think we will be continuing to evolve that. And someone has said in here as well as client appropriate, and again, those are all broad terms. And I think for us, the way that we will land the language is really through engagement with many of those that are most affected by the language and what resonates most with them. And so that is work that is ongoing with us. And I know in the space of long-term care, there have been some initial conversations about this as well.
Thanks. I see a similar comment to yours, Carol, from the person who's identifying as Bob in this webinar, saying, have we asked, the community what their preference would be?
Yeah.
And, it seems a bit obvious, but I think is an important perspective and approach. Sort of changing tact a little bit here is a question around, what's your best advice for policymakers about the role of policy, funding and other, in terms of enabling engagement capable environments?
Do you want me to start, Adrian?
Go ahead.
So I think this is a brilliant question, and thanks to Alan for asking it. I will say that policy, obviously, in the space of engagement and to really build in these philosophies of care, this approach to how we're going to do the work moving forward, policy is absolutely one lever that we need to try to pull on, and creating those environments, and we see in various legislations across the country, the language of patient or person-centered care that gets landed in, Excellent Care for All Act, and various acts that are similar across the country that will have similar language to put people first, the patient first, person first, that is receiving the care. And so the landing of it in policy is certainly one step, but we know it is often the implementation of policy that can be sticky. And interestingly, in some literature that I've seen, and literature coming out in research work coming out of the UK, where they have legislated different forms of what they call co-production, what they found was sometimes more tokenistic forms of engagement were popping up. So it became a checklist because they were told they had to do it. So it was a feeling of, thou shalt, and so therefore I've ticked the box, without truly doing the work of purposeful and meaningful engagement, and engagement that would truly influence policies, practices, programs moving forward. And so it's being able to thread or find that line by which policy can act as a very valuable lever to push ahead engagement work, but at the same time making sure that what is happening moving forward doesn't fall under the auspices of being tokenistic.
Yeah, and I would add, as we look across sectors and across the country, we find that policy is often a lever, but where engagement is really embedded meaningfully, it's in places where it's become part of their organizational culture, part of how they do their work, part of how they communicate with one another, part of how they see each other, how residents, patients, staff, leaders, how they see each other. And so it's in those places where we often see really incredible engagement practices. So policy is an important lever, but I don't know that it's the one that really creates excellence. Its excellence is when people start looking internally, they start being reflective, they're honest, they are humble about what they know and don't know and what they're doing and not doing, and they really tailor their engagement practices to their context, because it's so different between, for example, a long-term care home and an acute care hospital. Engagement practices need to be different and tailored appropriately to the setting. So it's really taking that policy lever and then looking reflectively at an organization and saying, how might we change culture such that we could enable meaningful engagement at that organization.
Thank you. I think your reflections, both of you, really align with a comment in the chat here from Andy Picard, who has some very rich lived experience of having, his late wife in long-term care, and having the privilege of a very engaged experience, but in contrast to what a lot of other people in his province are experiencing as a result of contracts that are being signed with large corporations. So essentially the feeling of there's warehousing, that it's just now a corporation that has to deliver a checklist of services, which is, on a very for-profit model. And they really move away from resident-centered care approaches. So just some alignment, I think, between what you're saying and what has been observed. And going back to your comments, Adrienne, around, policy is one tool, and perhaps that can help to address some of the way these contracts are set up, but ultimately it's happening really at the home level. There is a question that has come up around the contrast between the engagement capable model that was presented and a specific model of care, which you may or may not have heard of before, that is implemented in the Eden home. So it's called the Eden Care Alternative. And Eden is a care home that is a participant in some of our HEC programming right now. And they have a program that focuses on 7 domains of well-being. And I'm not going to do it justice in terms of my ability to describe the program. So, Adrian and Carol, I think it would be interesting, perhaps in future to get your reflections on the comparison, but they focus on, identity, growth, autonomy, security, connectedness, meaning, and joy as those 7 dimensions, and they have their entire structure, built around that. And so there was a question sort of comparing the two, and I don't know that it's fair to ask you to do that on the spot, but just, wanting to present that as a place to look into, and also just invite your comments on that.
I mean, I would just say, and I had heard of this philosophy of care before, and just I think these 7 domains are really reflective of resident-centered or person-centered principles, and I think that aligns very nicely with the World Health Organization's understanding of what person-centered care is. That it's focused on the needs of people, residents, and staff as well, because we know that if we don't have staff well-being, that we're not likely to have resident well-being. But the focus on people and less on systems, but about, what's good for people. And those 7 domains are really reflective, I think, of those things.
And the only other thing that I would add is that this notion of engagement, I don't know enough about the Eden model, but just hearing those 7 domains absolutely resonates. But it's thinking about how those domains come into play at different levels of the system. So engagement capable environments absolutely speaks to what happens at the level of care. What does that care look like? How well are people engaged? But it's really also speaking even more so probably to those meso macro levels of ensuring those lived experience perspectives are brought to bear when we're making changes at the organizational level and at the system level that do have bearing, obviously, back onto the direct level of care. So it's thinking about, for me, if I read about this model, I would be thinking about it of how does it have implications across all levels of a system, and what might that look like? Because that was really when engagement capable environments was really sort of formulated and thought about. It was really initially focused on that meso level, right? How do we help organizations to engage well across the organization when they're making improvements, they're thinking about priorities, so that they understand and are bringing in those lived experience perspectives.
Great, thank you for that context setting. And I think, there's a desire in this group, to acknowledge that it is at that meso level, like it is within the walls, that we can do a lot, but we could do more when we're looking at the higher levels of the system and looking at policy and looking at legislation, and how do we actually build this into the structure of our systems in a way. And I'm seeing that come up in the chat, with comments like it's a bigger debate than profit versus nonprofit, right? We're looking at the policy and the legislation to support the inclusion, but how do we do that in a way that it's not checklist again? So it comes, I think, to, the standards can be set at that higher level, but then how they are reflected at that meso level, I think, is really where the meat of it is. So we are coming to the end of our session in the last few minutes here. And I just want to reiterate a big thank you to you, both Carol and Adrian, for this amazing body of work that I hope will just continue to evolve and grow with support from this entire community that is on this webinar. I think there is a strong desire for engagement from the folks on this call in terms of moving this into long-term care in a formal way. And I think that the assessment tool is a great starting place, but just want to share that, HEC is always looking for new perspectives, for comments. What we do is living and breathing. This is not the one and only version. So please all do, share your feedback, your thoughts, engage with us if you want any support. I'll let you kind of carry on that thought, and then I will bring us to a close with a poll question. But any just last thoughts or comments or reflections from you, Carol and Adrienne?
Well, thank you so much for having us. It's not always that we get to the opportunity to talk about engagement in a long-term care setting, and it's a privilege to do so, because it's a place that it's people's homes, and they're more so, even perhaps more than in hospitals and in acute care settings, do we need to think really carefully about engagement and about the needs of people, because it is their homes that we're talking about. So really grateful to be part of this discussion.
Yeah, I just love the discussion. And it really, I think, reinforces to me how engagement capable environments, this notion of how we engage, why we engage, it really is about a culture change that we are trying to sort of underlie within the health and care systems, and that recognition of this value of knowledge that people with lived experience bring, and that it's different than what we have, but it's important, and we need to understand it as we are all collectively making decisions together.
Thank
So
you. I'm sorry. I'm gonna ask to leave it there so that we can use our final 30 seconds to invite everyone to participate in our poll. So if you have a second to do so, please do. The questions are whether or not you found the webinar useful. Will you share what you've learned with others? Do you know more about this topic than you did prior to presenting or participating in this webinar? What topics would you like to see covered in future webinars? And also, if you are willing, what is your gender, referring to what you internally feel, or the gender a person publicly expresses? Those are the questions we're looking for. And while you're doing that, I just wanted to also share that we have another webinar coming up on August 22nd. Our topic is still being finalized. We are putting together, hopefully, a very engaging lineup of speakers, wanting to really inspire this group around some of the amazing work that we want to showcase that different long-term care homes have been doing over the past year or so. So stay tuned for some more details. And once again, thank you so much for your engaging conversation, discussion, participation, filling out this poll. And once again, finally, thank you to Carol and Adrienne for your presentation, and to you, the audience, for joining us. This concludes today's event. Have a great day. Thanks, everyone.